Thank you very much for the invitation by the Brain Foundation and the organizers of Synchrony to give my presentation from cerebral folate deficiency to autism spectrum disorders, where I will focus on the folate connection. I'll talk about the first case history of infantile cerebral folate deficiency syndrome, the definition, clinical manifestations of CFD, the causes, the discovery of folate receptor autoimmunity, and then the discovery of association with autism spectrum disorders, diagnosis, treatment, and prevention. So let's turn to our first case, who was a boy of healthy unrelated parents. He had a normal development at the first 9 months of his life, and then the parents noticed a delay in the acquisition of motor skills, and at 18 months there was a standstill of development followed by regression with loss of speech, onset of spastic paraplegia, neuropathy, and ataxia, and marked agitation. The MRI of the brain and spinal cord was normal. So extensive investigation, including hematology, serum, red blood cells, folate, and homocysteine were found to be normal. So we then did a spinal fluid analysis at the age of 3 years, which showed a non-detectable 5-methyl-tetrahydrofolate, which is the circulating most active folate crossing the blood-brain barrier, and it was at 0. And you see secondary changes in the pterines and serotonin and metabolites. And a portion of the CSF fluid was used to study the folate receptor alpha protein, part of which is secreted. Normally it's anchored to the choroid plexus epithelial cells, and in this secreted portion you find a normal folate receptor alpha concentration, but the binding with radioactive folate was found to be very low. So we then studied the genes, which were normal, and we concluded that there was a non-functional folate receptor alpha protein at the choroid plexus, explaining why this child couldn't transport folate from his blood to the spinal fluid compartment and hence to the neural tissue. So after a while he saw him back, and in between he had received during 6 months 1 Flintstone tablet a day containing 400 micrograms folic acid, which is a huge dose, 5 times the recommended dose for a child of 3 years. And we heard the story and we saw that he had fully recovered in about 6 months. He attends now as the second year of a normal school, runs and rides a bicycle, and has normal speech and understanding. So here you see these Flintstone tablets, which were curing this boy who is now 8 years old on this picture. So we found a number of children with infantile cerebral folate deficiency syndrome, and here you see the constellation of symptoms which you can find in our publications, and in 1/3 you will also find movement disorders and severe epilepsy. If this is left untreated, you will have progressive visual loss and hearing loss from the age of 3 and 6 years respectively. So the transport of 5-methyl-tetrahydrofolate is done by a folate receptor alpha protein anchored to choroid plexus epithelial cells, which brings it first to the spinal fluid compartment and then through the ependyme to the neural tissues. You see that the intestinal barrier uses 2 other systems, the RFC and the PCFD systems, and that the folate receptor alpha has here a minor contribution. So we then define the cerebral folate deficiency syndrome as any neuropsychiatric condition where you find low CSF folate but normal folate metabolism outside the nervous system. So we describe several cerebral folate deficiency syndromes starting from different age groups. Here you see the infantile onset CFD syndrome. We now extended this with the infantile autism with neurological deficit syndrome, and we also found in Rett syndrome in a number of children low CSF folate. So you see spastic ataxic catatonic schizophrenia, which start at later ages. So 7 years later, we discovered the major cause of infantile onset CFD syndrome to be the presence of blocking autoantibodies against the folate receptor in serum of these children, while there were no blocking antibodies in control, healthy controls. And we then found that 4 of these 25 children with infantile CFD syndrome also had autism. So the autoantibodies against the folate receptor alpha anchored to choroid plexus epithelial cells will bind and block the binding of folate to the receptor, or can also bind and attract complement and cause an inflammatory response. So there are several other causes which I will not further discuss, like mitochondrial dysfunction and folate receptor alpha gene defects. Let's focus now on the correlation of these serum folate receptor alpha antibodies. When these titers are higher, you'll see that the CSF folate will drop progressively. So this will happen when 5-methyl-tetrahydrofolate transport to the brain will be blocked by these antibodies. It will cause, on one hand, a lot of changes in the intermediary metabolism like methionine and remethylation cycles, but it will also have an impact and reduce the purine and thymidine synthesis, with lower production of GTP and ATP, which are cofactors, precursors of the tetrahydrobiopterin cofactor, which is the common cofactor for the synthesis of dopamine, serotonin, and nitric oxide. Because the methyl tetrahydrofolate carries 1 carbon groups, these will enter the brain and normally will attach to the promoter sites in DNA, in genes, and the methylation of these genes will result in gene suppression, sometimes activation of genes. So there will be a disruption of gene expression in the brain when there is a folate deficiency. Here you see that over time we determined at 1-week intervals the titers, and you see marked fluctuations of these antibodies in infantile CFD syndrome, having sometimes cycles of 6 to 7 weeks. So you have high titers and low titers. The high titers will result in low folate in the brain and low production of tetrahydrobiopterin and low neurotransmitter synthesis, while when the antibodies drop, the folate transport will resume and there will be a reproduction of dopamine and serotonin, and there might be also overstimulation of earlier downregulated dopamine and serotonin receptors. From that point, we started to study the folate receptor alpha antibodies and the different folate receptor antigens, and we found that there was a 91% homology between the amino acid sequences from soluble folate receptor protein in cow's milk and the human folate receptor alpha antigen. On the right, you see here different representations of several antigens from human placenta, human milk, and here on the right, bovine milk and goat milk. And you see that there was a highest affinity of these antibodies with the folate receptor antigen soluble form in bovine milk, and that this cross-reacted with human milk, human placenta. On this picture, you see our hypothesis that the cow's milk soluble folate receptor protein and its peptides will sensitize in predisposed individuals the immune system, which will produce antibodies locally, and these will enter the circulation and will bind to the folate receptor alpha antigen at the blood-brain barrier and could induce cerebral folate deficiency. When you eliminate the diet from cow's milk, you will see that there is a significant drop of folate receptor alpha antibodies after 6 months. When you re-expose to cow's milk, you will see that there is a rise again of these antibodies. So there are 2 lines of treatment for CFD syndromes. The first one is the high-dose folinic acid treatment, where you use 0.5 to 1 milligram per kilo per day. This will raise the folate levels in the blood so that they can then be transported by a low-binding, high-capacity transporter called our reduced folate carrier 1. And this will be done to use an alternative pathway to enter the brain when the folate receptor alpha is blocked by antibodies. Second line of treatment is to impose a diet without animal-derived milk products. So use the human milk. It will not synthesize, but when the child receives cow's milk, it will synthesize and it can cross-react with the folate receptor alpha antigen from humans. So we then found a number of children with low-functioning autism associated with neurological deficits like you find in the infantile CFD syndrome. So we had 2 groups, 25 children with autism and neurological deficits and healthy controls, and we found that these children had low CSF folate due to the presence of a majority with folate receptor alpha antibodies. Treatment with folinic acid would normalize the CSF folate levels. So these folate receptor alpha antibodies in serum can be found throughout ages in 80% of Asperger syndrome and in children below the age of 3 in 86%, mostly children with infantile autism or Kenner syndrome. So also in infantile onset autism, you see these antibodies in higher percentage, and these also show these fluctuations. Sometimes they are minor than in the infantile CFD. So here you see, and on top, the CSF folate levels, the mean and standard deviation, and on the bottom, you see here down the folate receptor alpha antibody titers. And you'll see that the infantile CFD and autism with neurological deficits, that there are not much difference. They have generally low CSF folate in almost all children, while the group of autism will have CSF folates which are not always low, but the fluctuation could be responsible that you find only low, very low values in about 1 in 5 children. So they have still significant amounts of folate receptor alpha antibodies. So the only difference adding the tag autism compared to the infantile CFD group was that the parents of children with autism had folate receptor alpha antibodies, whereas the children with the parents from children with infantile CFD didn't have these antibodies. So here you see the family tree of a family where the grandfather and his son had autism, as well as the granddaughter. And in blue, they're all autistic, but the mother is not autistic, but she has antibodies, as well as her daughter and her brother and her father. So we thought that this was probably a form of epigenetic transmission, but where the factor inducing these epigenetic changes could be folate receptor alpha antibodies. But the question was why the mother was protected and didn't have autism. So assume that autism is a genetic trait for 100%, then the twin studies of monozygotic and dizygotic twins would be expected to have, when one child has autism, that the twin brother or sister has autism in 100% here, and in the dizygotic twins 50%. However, this assumption can be rejected because there are other called environmental factors, whatever they can be, who will diminish the concordance rate for autism, sometimes less in some studies, sometimes more in other studies. And here you see an example of monozygotic two boys. One had autism and his twin brother was normal. We didn't find an explanation, and we then asked everybody, how can you explain that the monozygotic twin, one has autism and the other not? What is the protective factor in the twin brother who is well? Even my grandson didn't know. So we then did the testing, and we found that the boy affected by autism was the only one having antibodies. He received high doses of folic acid, and this resulted in complete disappearance of autistic signs and symptoms after 2 years treatment. So then we turned to study a self-controlled trial among about 200 children with infantile onset severe autism, and we had two treatment groups. One group receiving no treatment, and the other group receiving high-dose folic acid and correction of nutritional and antioxidant deficiencies. We then monitored these children and we assessed them for the childhood autism rating scale and developmental test after 2 years. Here you see the childhood autism. The higher the score, the more severe is autism. You have below 30, there's no autism. Between 30 and 36, it's mild to moderate, and above 37, it's severe autism. And you see there was a significant drop after 2 years treatment. So the untreated group didn't show any change of their CAR score with advancing age, whereas the group having treatment showed at each age group a significant drop. And when you looked at the profiles of antibodies where the child, mother and father were tested, you see that all groups had drop in the CAR score and improved. But when the parents both tested positive, there was no significant change. And we also noticed that when the mother tests positive, that will increase the baseline CARs and also affect the final outcome, which will be less marked. So the early detection of folate receptor antibodies was found to be positive. The younger you treat, the lower the baseline CARs and the better the outcome. And we knew that folate receptor antibodies in mothers would block the folate receptor alpha, which is the main site of transport of folate to the fetus, and you find these antibodies in 10 to 5% of the US population. So we selected here young children below the age of 3.5 and compared them. When only the child tested positive, you see that there was a significant change. When the mother tested positive, the baseline CARs was higher and the gain in the drop, well, the change in the CARs was less marked, and when both parents test positive, there is no significant change. So we then did a prevention trial, or started this trial, among parents who tested positive, and we gave them folinic acid after genetic counseling, excluding genetic origins of autism. So these parents had one child with autism and wished to have other but normal children. So you see that in these three families, there were 5 siblings born, which were all normal. We also treated in the second family the father 3 months before conception and during pregnancy. So Ed will talk about folate receptor antibodies in one particular case. So our message is to test serum antibodies among future mothers and fathers to treat with folinic acid, to stop epigenetic derangements due to methylfolate deficiency in the child, because these epigenetic derangements can affect future generations and be transmitted, and screen folate receptor antibodies among infants and young children as soon as they show the first signs of autism, and start treatment as soon as possible. So I thank you for your attention. I thank the Brain Foundation and Synchron, also the people from Zurich who helped me a lot on the CSF analysis, Ed Quadros and Jeffrey Sequeira for the help in the autoantibody testing, and the Center of Autism, which I headed the last 10 years.
Wow, that's a wonderful talk. Thank you so much.
Okay, you're welcome.
We have some time for questions. Is there any questions?
Yes. I have got 2 questions. One of the questions was that for severe CFD, very low CSF folate, is there any indication that using leucovorin injectable could yield better results than oral? I think when you have, for each child with a very low CSF folate, methylfolate, certainly when it's below 10, this should be an indication to analyze the folate receptor alpha gene, because this could really be a cause of with a folate receptor alpha a gene defect, which will lead to a loss of function. And there are several cases reported, and there was one case who had very severe intractable epilepsy, and the only way they could treat it was by giving high dose injections of leucovorin. So, but I would suggest to the person who had the question that first let's do an analysis. Is it mitochondrial? Is it folate receptor alpha gene defect, or are there antibodies? And to decide on the results what kind of treatment you should give. But for practical reasons, I think you can give a treatment. And you know, I know you give up to 50 milligrams. So we start with a dose of 0.5 to 1. and we up or double the dose when after 3 months there's not much progress seen. Then I had a second question. I would like to know what specific types of folate supplements, calcium folinate drops or L-methylfolate, should be used, and what might one consider as a starting dose for children 9 to 12 years old who are heterozygous for the C677T mutation polymorphism in the MTHFR gene. I don't treat children who are heterozygous except when, but because I think only I treat those who are homozygous, and I think you should prefer methylfolate over calcium folinate because you will give, instead of the, you will give the product and not the substrate, you know, which is blocked by the enzyme, which has in a homozygous form about, they say, 50% reduction of enzyme activity. But I see in these homozygous children, mostly you see children from the Mediterranean region, they improve on the high dose riboflavin, how do you call that? Vitamin B2, because this is known to activate the gene, this gene when it's mutated.